Good morning and welcome to a lecture on skeletal muscle and peripheral nerves. So it's relatively short. Muscles usually work for you, but when you have a common complaint of muscle weakness, something like that, you need to look at either it's the muscle or the nerves serving the muscle. So myogenic or neurogenic origin of this issue. And so neoplasms or cancer muscle is pretty rare. But we'll hit some muscular dystrophies and peripheral nerve issues. All right. Well, quick review. We're not going to go through everything about muscle, but you do realize that muscle is, the fiber is the same thing as a muscle cell. So it's a huge cell in terms of cells. And because it originally in embryonic life, it came from several different cells that melded together. So it has many nuclei. They're just squished to the side so that the whole middle can be filled with the proteins actin and myosin. So they can slide by each other for muscle contraction. And then you take all these fibers and you organize it to these fascicles or these groups. And you have connective tissue coatings around them. Remember perimysium, epimysium. And they all are going to come together into tendons, which will insert into the bone with a really tough connection. In fact, it's so tough that often the tendon doesn't snap, but you pull off a piece of bone called a avulsion fracture when you do that. So the fibers that are in the collagen in the tendon go deep into the bone itself. They get enmeshed in it. So it's not just a tendon attached to the periosteum weakly. It's a nice, tough connection. And so when you look at this cross-section of muscle over here, you see all those little tiny pink dots. These are the proteins. These are coming at you from this section. And those dark nuclei found around the periphery. And of course, it's banded because you have sliding filaments. Enough said. Well, I'll tell you a little bit more. Now, importantly here for this lecture and for some of the diseases is that all of the muscle, skeletal muscle, is innervated by motor neurons. And they're somatic. You control them. And gorgeous histological slide here. And you can see those motor end plates where, remember, acetylcholine is released. It's going to hit acetylcholine receptors. The signal is going to travel in the muscle down T tubules to get deeper, right? Sarcoplasmic reticulum is going to release calcium ions. It's going to cause tropomyosin move out of the way. Then there can be the cross connections. Yeah. It's just jogging your memory there, right? And so one motor unit is going to be what one axon goes to many fibers. And motor units can be big, like in your big quadriceps or gluteal muscles, where one axon goes to thousands of fibers, or small, as in some of your finger muscles, especially your ocular muscles, the muscles that move your eye, where one neuron, one axon may go to just half a dozen or just a few fibers. So you have really delicate control where you need it. And this illustration shows it nicely. It shows, see the different colors? Each one of those populations is being innervated by one axon because the axon splits and goes to several fibers. And yeah, and I said a little bit more. So yeah, just always good to review, take a look at this and see why is it banded, and then they slide by each other, and then yep, calcium gets us all started. Enough said. In terms of muscle fibers, you've got slow twitch and fast twitch, or type 1 and type 2. And you don't notice it just taking a look normal histological slide, but you can specially stain for this, and you can take a look. And so you can get someone on an exercise regimen and do a muscle biopsy before and after and see if it's their endurance training, if more slow twitch fibers come out. But just as you know, slow twitch is more sustained, and fast twitch is going to be more powerful, quicker contractions, but it cannot be sustained. And it's the reason why a duck is all dark meat, and then a chicken is, the legs are dark meat and the breast is white meat. Because chickens don't fly south or anything. They can fly rapidly, but then they tire out, right? And so see that distribution. And muscles that are involved in more endurance have more myoglobin and more capillary beds because they're doing aerobic respiration, right? If it's fast twitch, it's good if you're just a linebacker just coming off the line, you can rest, or a sprinter, things like that, where you get the maximum power, but it's not sustained because you're doing anaerobic if pretty quickly. All right. So from an earlier lecture talking about people think, oh, I can become anything you want. Well, you can't. You can't because there are people that are born to run marathons because genetically the amount of fast twitch and slow twitch, those distributions vary genetically among people. And, no amount of training could I win the Boston Marathon. None. People will tell you, you can do anything. No, you're just not genetically there to do that. So I digress. All right, so the nerve, we're going to do the next lecture I have is on central nervous system, brain and spinal cord, but your peripheral nerves come out of spinal nerves, right? You got a big plexus, brachial plexus in your arm, and a lumbosacral plexus, including the big sciatic nerve that goes down your leg. And those peripheral nerves are going to send motor impulses out, sensory impulses coming back in to the central nervous system. And there's motor, and then the autonomic system too goes to smooth muscle in your organs and in your blood vessels. And so sensory comes in and motor goes out for autonomic nerves. And then somatic nerves would be things you control, like your guns. Autonomic nerves are unmyelinated. Now, when I say that, they still have a Schwann cell that kind of envelops them a little bit, but myelinated axons freaking have all these layers of this fatty myelin to insulate them, and it makes a much faster transmission. So how fast do you need to know if your tummy hurts, Right. As opposed to if you step on a nail or a piece of glass, how quickly that needs to travel. So it makes sense when you take a look at it. And the bigger the nerves, the more rapid the transmission as well. You guys remember that? And then motor sensory, the ones that are fast are myelinated, but there's some unmyelinated ones too. And so you can see this is a beautiful electron micrograph showing all the layers of myelin. So a Schwann cell just coats this beautifully. And then what I want you to know too, talk about this, what's important in pathophysiology. If you cut a nerve, spinal cord injury does not heal, right? It's a lot of research going into that, but nerves, you can, if they get reconnected quickly and they're close, they can reconnect. But if they're off, you've lost that connection forever. And the muscle that it served is just going to atrophy because muscles need that nervous connection to stay. Once you cut the nerve, the muscle just goes away. It's going to be important in a lot of these diseases. And they can regenerate, like I say, if you cut a axon, it will start sending out little rootlets and try to find those Schwann cells will kind of try to guide it so it can reconnect. But if it's not close enough, it won't reconnect. The neuromuscular junction, of course, at the end of the axon, you'll have this bulb, and then there'll be a motor end plate on the muscle. And then the impulse, the action potential comes down, right? Yeah, calcium ions are going to enter. Then these vesicles filled with neurotransmitter. You guys remember what chemical that is? Acetylcholine will be released. There'll be acetylcholine receptors on what's called the motor end plate. And once they are filled, then the nervous, the signal will travel along the muscle to cause it to contract. And then you need to remember the enzyme that breaks down acetylcholine. It's acetylcholinesterase is going to break it down, and you're going to reuptake that. So all these things are necessary for normal muscle function, a motor function, where neurotransmitter comes out, muscle contracts, neurotransmitter taken away, muscle relaxes. But in paralysis, it can be or tetanus, you can have the signal constantly. You don't get rid of the neurotransmitter, right? Or there's a blockage. You block up, you gum up those receptors, and then you can no longer use that muscle. So for things to happen, you have to have everything working. And there's diseases, and talk about botulism and all kinds of things that affect various parts of this. All right, so what's the most common issue? People come in with muscle weakness. It can be because you can notice the muscle is atrophied or not. And we'll talk about muscular dystrophies. And these are pretty rare, but they're genetic conditions where the muscle sadly progressively declines. Yeah. some diseases like this where we have no known cures. Yeah, very sad. You could have muscle weakness, could be because, well, any kind of stroke or spinal cord injury, of course. Could be a cancer. There's some rare nerve cancers that happen in peripheral nerves. It could be trauma, injury, gunshot wound, things like that. You know. Now the peripheral nerves. You'll see a common complaint is this peripheral neuropathy, where you lose sensation in your extremities with diabetes, and so that's why it's common. Yeah, leprosy. It's not very medieval, but it's a bacterial disease that affects peripheral nerves, but and other things too. Probably won't come on most of that in the U.S. Yeah, so it could be the nerves could be inflamed. Definitely diabetes. You can see the blood supply to the nerves, and then the nerves start dying there. And there's all these neuropathies that can be hereditary. All right, toxins. You can see heavy metals and things could be the cause of this neuropathy, and the Schwann cells in the neural lemma can be cancerous rarely. So peripheral nerve issues. And this could give you some clues when you talk about which muscles are weak. We'll see if it's the proximal muscle groups, the muscle groups close to your body, it's a sign that it could be a muscle problem. Now, if it's your distal muscles that happen to be in your feet and your hands, it really points towards a nerve issue, because the nerves have to travel a long distance. And so the ones furthest away are going to be affected first. And if it's a muscle problem, that's not necessarily the case. So again, there are clues that let you know, hey, is this muscle weakness due to is the muscle damaged, or is it the nerve going to it damaged? And so that's a clue. What muscles are affected? Is it bilateral, or is it just one side? It's going to tell you, maybe look for trauma or something on one side. You can just simply look at atrophy. And many, the major case when you look at cancers or things like that, people that are bedridden, they're going to have atrophy. They're not going to be moving as much, and so they're going to have muscle weakness due to that. And any stroke or neurological impact is going to affect muscles as well, because that's where the control is for the muscles, right? So, yeah. Pain usually means there's some inflammation, and yeah. So what kind of tests you can do? Turns out you can take a look at a blood workup and see about the creatine kinase. There's many reasons you could have that, but it's when muscle breaks down, that's in high levels. So high levels of creatine kinase, you're like, oh, they got something, their muscles are not happy. Electromyography, you guys know if you did that in your A&P class, but you can put a needle in the muscle and look on a computer screen these days and see the activity of the muscle. And it gives you some clues about how the muscle reacts to electricity, whether it's neurogenic or myogenic too. So EMG can be done. And a biopsy. They put a needle into a muscle, and then they can stain it, look under a microscope, and they can tell you have a muscular dystrophy or there's a whole bunch of neutrophils in there. So biopsy is good. These peripheral nerve tests. So you go in, you're like, I can't feel anything in my left leg, my shin, and my foot, things like that. So you'll do some tests, of course. They can do this 2-point discrimination where you see, how sensitive you are. You can do things like the knee jerk, and that's involved with the central nervous system too, but it could so it doesn't really rule out that it's a peripheral nerve issue. But so you can do neurological tests, nerve conduction test. We do this in my A&P class, and yeah, you put some electricity, you measure when the muscle contracts. If you know the distance, you can get the nerve speed. And so you see in some diseases, the nerve speed is greatly slowed down. You break down the myelin, it's just going to make it a lot slower. And you can't do a nerve biopsy. They can get a piece of nerve to look in the microscope to see if it's a demyelinization disease where the Schwann cells are attacked. Usually find a sensory peripheral nerve. You can take a piece of that. You don't want to grab a piece of your sciatic nerve or something like that, but yeah. Yeah, so taking a look, looking at myopathic versus neurogenic. So that muscle weakness, is it due to the muscle itself, or is it due just to the signal coming to it? So you can take a look, like that creatine kinase. It's going to be not a big deal if it's a nerve problem, but if it's a muscle breaking down, you can have high levels of it. That'll tell you that. Electromyography, you can see if it's a muscle problem, you'll get just kind of spontaneous activity. With the nerve, it'll work when the nerve goes, but it'll be just a lower activity if that nerve is damaged going to it. Yeah, proximal weakness, muscle groups close if it's a muscle problem, distal weakness if it's a nerve problem, because that nerve, the more distance, and if there's a problem with conduction, the more issues you're going to see further away, right? Yeah, and you can do a biopsy, and I'll show you later. It's pretty cool. Just do, if it's the problem is the nerve. Remember those motor units? You're gonna, if you look at a muscle biopsy, you're gonna see these groups of neurons, of muscle fibers that are tiny in groups, and other ones are normal, because the axon involved is going to go to several. So you see this characteristic look. We have normal muscle, and you have these groups of really atrophy muscle fibers, and that means it's not the whole muscle going on. It's just the axons going to certain muscle groups in that motor unit. Anyway, so got to be detective and to figure out what's going on here. All right. So we'll talk about diseases now. And so dystrophies, the name's not really appropriate. Dystrophy means, trophic means feeding. And so it's not about feeding, but it was named because the muscles would, these diseases would be this muscle wasting. Muscle gets turned into just fat and connective tissue. It's often a long-term, over years of this wasting with no intervention that's really useful. So it's tough. So many different types. It's genetic, so it depends what the mutation is. So they can identify that and figure out what type you have. Some come on early, some come on later, definitely, which muscles are involved. Yep. And again, no cure. Yeah. What bad ones is this Duchenne muscular dystrophy, and it is sex-linked. So again, the X chromosome, and what happens is that usually your boy, 3 to 5, shows some muscle wasting, some issues, some unsteady gait, things like that, and then just goes downhill. And you're in a wheelchair by 11. You may live to be about 25 years old or so, because the muscle, more and more muscles become involved until all these things at the end, the breathing muscles are lastly involved, and then can't live anymore. So it's a mutation. And it has to do with just one of these proteins, not the actin and the myosin, but these other proteins that are involved, this dystrophin. It's used to keep the muscle fibers like attached to that connective tissue. And if that's not there, the muscle moves and it just degenerates. So it's this minor, less than 1% of the protein in there, but that you need it to have normal muscle functioning. Yeah. Oh, the calves are hypertrophy because it's actually fat, it's not muscle, yeah. And there's a less severe form of it as well. But yeah, this is done kind of this imaging, and take a look. You can see you start out with the muscles, and then you're just wasting. It's replaced it by fat. Yep, and you can see the mode of inheritance. You can see you can be a carrier of it if you're a woman, but if you're a man with it, you have it because you'll have 1X. And you end up, again, through childhood, just adapting, with your muscles just failing you. And you can see histologically how the muscle fibers just regress. And this shows, we saw early on a normal, healthy muscle cross-section. Take a look at this. You see the fibers there's big ones and small ones, there should be a little variation, but this is all over the place. And then they're way too spread apart. There's too much connective tissue. So this just looks like very abnormal muscle. Just one slide on this. There's this myotonic dystrophy. Interesting in that person like shakes your hand and doesn't let go. So you have the contraction, but you don't let go. And you can live quite a while. You have a characteristic look with this male pattern, baldness and normally low IQ. Exactly, you can see cataracts and other issues with this muscle wasting. So, yep. So yeah, they'll notice this, and then they'll do some genetic testing. They'll do some muscle testing, a biopsy, and they'll they'll conclude that you got myotonic dystrophy. All right, the CMT, this is diseases, and the muscular dystrophies are affecting the muscle fiber, right? This is affecting the peripheral nerves, but it has similar manifestations. I mean, you're gonna have the same kind of wasting, but it's not because of different causes. So you can have axon issues or the myelin around the axon issues that are going to cause more and more of slow progressive degeneration of your muscles because the nerves feeding them are not great. Incurable disabilities. Yep. All right, inflammatory degenerative diseases. Yes, so you could have muscle inflammation and weakness because you have a vascular disease, atherosclerosis to a particular area, or some autoimmune kind of thing, or metabolic disease. You need calcium, various things like that for muscles to work properly. So there's other causes possibly of these muscle issues. Inflammatory disease is polymyositis, which means it's an autoimmune disease where you attack your own muscle cells. Yeah, yeah. And so looking at this histological slide, you see, oh my God, these are all neutrophils? What the hell are they doing, around all these muscle fibers? So you're gonna see tons of lymphocytes and neutrophils and things that are attacking the muscle fibers in polymyositis. Dermatomyositis is when you also have the skin rash involved too. And usually the inflammation is not between the muscle fibers, but in that paramycium or epimycium, just underneath the connective tissue layers. But both very, a lot of commonalities here. They're just two autoimmune disease of muscle. So you're going to have muscle weakness, the pain and tenderness with this inflammation, right? Creatine kinase is going to be up because you have a muscle destruction. Yep. And steroids. Steroids are the way to go they bring down inflammation. All right, some neurogenic disorders. And so I show again here, once you stop the nerve connection to a muscle, that muscle is going to waste away. So always keep that in mind. You need that connection between the nerve and the muscle. The muscle listens to the nerve, and if that signal doesn't come, it just wastes away. Yeah, and you need to figure out, you have this, what is the issue? What's causing this, definitely. And you can see here another instance here. I know that one's much older, but when you have this kind of muscle replaced by fat and connective tissue, is if you lost a lot of nerve connections to that leg muscle, and then it's just gonna regress like that and atrophy, and you're gonna have more weakness. So look at this is so cool. This shows, imagine you have here's the axon coming in, and you have like an action potential there, and you have a normal axon going to these, and then you've got a damaged axon going to these. So what it shows is this is a motor unit of this axon that's damaged, and the perfectly normal muscle the axon is not damaged yet, right? So neurogenic atrophy is going to show this characteristic. You do a biopsy, this pattern where you have groups of muscle fibers atrophying and other groups appear normal. All right, so indicators, pattern of muscle involvement, again, more distal muscle groups in your hands and your feet will be indicative that it's a nerve issue because it's farther to go. And then imagine if you have a motor issue with a muscle, it seems very weak, and you also test the sensory function also. You see, how do they feel, 2-point discrimination, how good is their senses here too. Now, if both of them were affected, that's really good evidence that it's the nerve feeding it. Now imagine it's muscle, but the senses are normal there. That points to the muscle being the issue. So it's really helpful to, you have this muscle weakness, to also test how are the senses, because they're carried by the same nerve fiber. And so if the nerve fiber is being attacked, you expect both sensory and motor to be affected. If it's just motor that's affected, it's probably the muscle, and the nerve is fine. All right. Yeah, and yeah, physical therapy, often take a look at to try to increase range of motion and exercise to move the muscles. All right, famous disease is Lou Gehrig's disease, or ALS, and it's a chronic disease that doesn't appear until adulthood. And so here are adults like Lou Gehrig, top physical specimen, baseball player, and all of a sudden you start out with muscle weakness, and then it just progresses over years until more and more of your body, the muscles are destroyed, until eventually it kills you within years, a few years. So again, you don't know you have it. It's a genetic disease, and then all of a sudden, bam, you're hit with it with a prognosis of you have a few years to live. And those years will include you just wasting away and losing the ability to walk, talk, everything. So, yeah. And a couple of GIFs down here showing you these muscle fasciculations, or something that happens as the nerve's dying. You know, the muscle works, kind of goes on its own because it's unhappy. Good example, Stephen Hawking, you know, had ALS. Yeah, average duration 3 years, but that varies. And once they diagnose it, so you have this progressive genetic issue. Yeah, and what's causing it is that you have a breakdown of the nerves that lead to these muscles that we don't know how to fix. All right, myasthenia gravis is it's not really an issue with the nerve, and it's not an issue with the muscle. All right, but it's an issue with the motor neuron junction. It's at the synapse. That's where the issue is. And what you have is it's an autoimmune disease too, where you make antibodies that attack the acetylcholine receptors on the muscle. Okay, so the nerve sends acetylcholine like normal, but you have like a third of the receptors, which means the muscle doesn't really react. Yeah, and so characteristically, it happens in the facial muscles. You'll see kind of drooping, like a lack of expression, because those muscles will be affected. And it's possible, you know, what causes this autoimmune? A lot of these we don't know autoimmune, what causes it. It could be some infection where the organism that was fought against has a similar molecular characteristic of your acetylcholine receptors. So it's this, you know, goes after your own body when it originally made them for bacteria. Sometimes you see it when there's a tumor in the thymus, and so you can remove that. It sometimes helps. Yeah, and so it runs years of myasthenia gravis, and it's a pretty rare disease. But you think about drugs that could help with it. I mean, you could do a blood transfusion to get rid of the antibodies, but they're going to come back. But any anti-cholinesterase drugs will leave the acetylcholine in the synapse longer. You know, you don't have the enzyme to break it down to recycle it. Leaves it in there longer, and your muscle is going to react with fewer receptors if you don't break down as much. There's more of it in there. And it's not in your book, but I thought I'd throw it in here. Botulism is a toxin given off by a bacteria. So if you do improper canning, you know, home canning, I see that a lot now. People are canning like fiddleheads and stuff here in Maine, and they do it with a way without autoclaving to kill all the bacteria, and it seems a little dangerous to me. But this bacteria is ubiquitous. It's found everywhere in the soil. That it's anaerobic, so it likes, you know, no oxygen, and it causes paralysis. So botulism is life-threatening, and so it's going to paralyze your breathing muscles, all your muscles. We use it now, you know, cosmetically too, to paralyze muscles so you don't have wrinkles. It's not in your book either. I mean, I haven't done the infectious disease lecture yet, but polio affects muscles as well. So it's a virus that affects your motor neurons, and so we're talking the central nervous system, but the nerves go to the muscles, and so you'll have muscle weakness and atrophy, especially lower limbs. Muscles get smaller and smaller, and if it continues on, your respiratory muscles lose their motor ability, and you're in an iron lung. Now, in the 50s, it was millions of children. Parents were so scared. The kids, if they got a cough, it could be polio, and they know the kid's going to end up on crutches and debilitating. So, but luckily we came up with a vaccine. And now polio, we've almost eradicated it from the earth. It's found in just a couple countries, a few countries where it's just hard to get everyone vaccinated, but smallpox was a horrible, horrible disease that we got rid of. Polio, we're close, but we can still get polio. And it's this viral disease that affects the motor neurons that go to muscles. So throw that in there. All right. There's a big old name up here, acute inflammatory demyelinating polyradiculoneuropathy. Woo! Yeah, the other one you need to speak French is also called Guillain-Barré syndrome. And yeah, pretty famous disease. It's the multiple sclerosis, or MS, of the peripheral system. MS is in your brain and spinal cord. Guillain-Barré is the same demyelinating disease in your peripheral nerves. You can see how rare, 6 to 40 cases per million. Right? So it's a rare thing. But you'll have proximal muscle weakness, and it could be Guillain-Barré. So if they did a nerve biopsy, they would see your myelin is being attacked and gotten rid of. And we don't know what exactly causes it, but it's probably autoimmune too. You often see people get a GI tract or respiratory tract infection weeks before, and then you see some onset of this. And so it's possible antibodies are attacking the myelin, but we don't know. All right, now diabetics. Oh my gosh, we talked about how it affects your eyesight, how it affects your blood vessels everywhere. Well, here we go. Another symptom of diabetes is diabetic neuropathy, where you get losses of sensation in your extremities. And so you can see common neuropathy, because diabetes is increasing in our country. We have more cases of this neuropathy. And yeah, so it could be symmetrical or asymmetrical. It's usually extremities, of course. So you lose that blood supply to the nerves, and they're going to start regressing. You're going to have less function. All right, almost done. We'll talk about, what about neoplasms? You know, we talked about bone cancer and skin cancer. What about muscle cancer? Well, pretty rare, pretty rare. A few things metastasize to muscle, but there is a rhabdomyosarcoma, is malignancy of muscle. So muscle can become cancerous, but pretty rare. And then there's a couple other ones. It could be for peripheral nerves. We're talking about both in this lecture. You could have tumors, schwannoma on a Schwann cell could become tumors, or neurofibroma, the covering around the nerves. So there are some cancers of the peripheral nerves, very rare, and there's primary muscle cancer, this rhabdomyosarcoma, but rare as well. All right, organ failure. Your muscles fail. So obviously, you know how that's going to affect. If your lower extremity muscles fail, you're going to be in a wheelchair, etc. So if you have a muscle that is paralyzed or not working, it could be a dystrophy, just working at that area, right? It could be some kind of trauma involved. You could have cut the nerve supply. You could see a hematoma. The muscle could be issues like that. It could be inflammation because of some reasons we talked about as well. So that's one thing. If you're seeing like all your muscles fail, you want to say, is this acute or chronic? Now, you can make quickly all your muscles paralyzed with certain paralytic drugs, and they'll use these for surgery, medical regions, and curare-like drugs. Yeah, curare comes from a plant in the rainforest, and they'll tip their darts, and you hit a monkey or a parrot, and they'll be paralyzed and fall pretty quickly, and blocks the neuromuscular junction. Yeah. Botulism is when it causes you can't release acetylcholine. Myasthenia gravis is when acetylcholine receptors there's fewer of them. And then things can also work in acetylcholinesterase. So that neuromuscular junction, you can have drugs that work or diseases that work there that affect the muscles, right? Yeah. And then chronic muscle failure, I'd be looking at some kind of dystrophy, some kind of, it's either myopathic or neurogenic that we talked about. So It's if your muscles are failing, we got to look at these big diseases that cause this. Not real common diseases, but diseases that obviously have a big impact on the patient's life. So in these diseases that we've talked about, the end result eventually is paralysis of breathing muscles, and then put on a ventilator, and you have a chance for infections and pneumonia. So that's usually where you're going to succumb to. You know, you have ALS, you have years and years of just progression of less and less use of your muscles, and eventually it reaches muscles for breathing, and then they've got to put you on artificial ventilation, and that has issues where it's not conductive to a long lifespan. All right, very good. Again, talking about these progressive diseases like ALS and stuff, it's hard to not. I think it's coming through. I feel just a little depressed, or at least have empathy for people with such diseases. So yeah, but interesting stuff. And you guys, as you can see, there's a muscle weakness, and it will come in definitely with the increase in diabetes, and people look at peripheral neuropathies, and you'll come across some of these rare muscle or neurogenic diseases as well. All right, have a great day, you guys.